following is a production of West Virginia Public Broadcasting.
Major funding for Doctors on Call is provided by a grant from the Milan Charitable Foundation. Other funding is provided by the Health Plan, a health maintenance organization serving West Virginia and Ohio since 1979. By the Center for Organ Recovery and Education, supporting Volunteers for Life through organ, tissue, and corneal donation. By Health South Rehabilitation Hospital, serving your rehabilitation needs in Morgantown and Fairmont. And by the faculty and staff of the Robert C. Byrd Health Sciences Center of West Virginia University. Welcome to Doctors on Call. Tonight's topic, stroke. Two experts are here to answer your questions. Now here's your host, Dr. Kathy Moffitt.
Good evening. A stroke is a brain attack. It strikes suddenly, often without warning. In a stroke, vital supplies of blood and oxygen to the brain are cut off, either by blocked arteries, called an ischemic stroke, or ruptured arteries, a hemorrhagic stroke. Are you at risk for a stroke? What are the symptoms? Which procedures, medications, and rehabilitation can help people recover? We'll get the answer to those questions and more tonight from our two guests, Dr. John Brick, Chair of Neurology at West Virginia University, and Dr. Lori Gutman, who's also a neurologist at WVU. We'll be taking your phone calls via email tonight because our phone lines are down in Morgantown. If you'd like to ask our guests a question, email doc@wvupubcast.org. That's doc@wvupubcast.org. Before we get to your questions, we'd like you to meet John Lako, a stroke survivor. Here's the background report.
83-year-old John Lako plays cards as part of his rehab after having a stroke. Picking up the cards is helping him restore dexterity in his right hand. It was just a month ago when John's wife, Sophie, suspected he was having a stroke, when his right hand wouldn't stop shaking and he was having trouble talking.
I mumbled at times, mumbled jumbled or whatever you want to call it. Couldn't talk right at times. In times I couldn't talk right.
Speech changes, numbness, weakness, and vision changes are all signs of a stroke. Sophie called an ambulance and got John to the hospital quickly. Since the hospital was a certified stroke center, the stroke team was ready and waiting for John at the emergency room door.
More than 20 beepers go off when they page the stroke team. That includes the team of neurologists that's involved, the neuroradiologists, the pharmacy, the labs, all the different people that are going to be involved in getting this patient to treatment as fast as possible.
John was hustled into a CT scan within 15 minutes, and the stroke team determined a clot was blocking flow of blood to the brain. He was given TPA, a clot buster medication that can significantly reduce the disabling effects of a stroke.
If you have a stroke and you are in the emergency room within a 4.5-hour window, you can get IV therapy. That's a clot buster. It's called IV TPA, and that drug helps to break down the clot that's blocking the flow of blood to the brain.
Treatment depends on the type of stroke that you have, but if you get to the hospital after that 4.5-hour window, treatment for an ischemic stroke becomes more complicated and risky.
You may not be able to get the use of an arm or a leg back. You may not be able to speak or understand. You may not get sensation back. So the faster you get there to be able to reverse that, potentially, the better your outcome.
John is gradually regaining full use of his right hand. He practices writing his name with a modified pen that's easier to grip. Time is brain when you're having a stroke, and the after effects of John's stroke were minimal because he got to the hospital fast.
Well, if you get to the hospital early, this could happen, It don't have to be worse. It could be better. And which he got better in 3 days, really.
With the background report, this is Amy Johns reporting.
So we're so glad he's getting better. Our topic tonight is stroke. Our guests are WVU neurologists Dr. John Brick and Dr. Lori Gutman. Again, our phone lines are down, but we'll be happy to take your questions via email. The address is on the screen. So, John, stroke is a really big problem in West Virginia. Why is that?
Well, we're blessed with an elderly population, but the risk factors for stroke are very common in the population we take care of in West Virginia. Diabetes is very common, certainly hypertension, hyperlipidemia, and obesity, and cigarette smoking. All of these things are major risk factors for stroke, and unfortunately the population in West Virginia is prone to have these problems.
Right. Now, Lori, sometimes it's subtle. You don't come advertised saying I'm having a stroke. How do you know that you're having a stroke?
A lot of times when people think about stroke, they think, oh, my whole side's going to be weak. But many times people might just have some incoordination, so some clumsiness, or they might have some difficulty talking. They might have trouble finding words, or they might not have any trouble finding words, but they might not understand very well what's going on around them. It could just be some numbness. It might be some vision changes. So, the issue is that the brain controls pretty much everything we do. So if you have a stroke somewhere in the brain, depending on where it is, that's what the problem's going to look like.
So John, in the video, was having some speech problems and then just a little bit of clumsiness with his hands, and they recognized that was...
He had some shaking, some uncontrolled movement of his hand.
Right.
And his wife and he both recognized that there was a problem and did the right thing, went to the hospital right away.
Right.
And that's really important. As his wife pointed out, I mean, his good outcome was based on the fact that he got to the hospital quickly.
So, John, you call 911, or do you call your son or your wife, or what do you do?
You call 911, and you go to the local closest emergency department as quickly as you can get there. Because as Lori said, the key to the whole thing here is get to the patient quickly, get a rapid diagnosis, and give them the treatment that's available. The saying that we use is time is brain. The sooner you get to the hospital, the sooner you get the medication, the better the outcomes.
So within 3 hours?
Generally within 3 hours. The medication that we give most commonly is TPA. It's given in a vein in the arm, and we like to give that within 3 hours. There are occasional instances when we can extend that window out, say, to 4.5 hours. And in very specialized centers in the state, we can actually do other therapies out beyond that 3.5 or 4.5 hour window. And occasionally we are successful. But the whole key to this is get to the local hospital as quickly as possible and get the IV TPA, because that's still the gold standard treatment for this, for an ischemic stroke.
Yeah, right. And the other issue about it is, even though we say within 3 hours, the sooner after your symptoms that you get the treatment, the better your outcome. The longer you wait, the higher the chances that you can have a problem from the treatment. So the treatment is a clot buster, but because of that, it also increases your risk of having bleeding in the brain. So if there's if you get there sooner, you're going to have a lower risk of getting bleeding from the treatment. So we always say don't wait to see and then say, well, it's been 2 hours and it's not gone yet, so maybe now I should go to the hospital. The issue is you want to say as soon as you get the symptoms, you need to get to the hospital.
And if you have the little warning strokes, the TIAs that go away, the transient ischemic attacks.
I believe you need to go to the hospital then too, because the data shows that if you have a transient ischemic attack, the risk of stroke is very, very high in the first few days after that occurs. It begins to trail off after that. But you want to get to the hospital so the doctors can find out what's going on and develop a treatment regimen to prevent you from having the big stroke. And the way to do that is get to the hospital quickly, immediately. Don't mess around. Go to the hospital.
Right. Now, there was a mention of stroke centers. So there's only a few in West Virginia, and you mentioned that some of the other treatments. What are some of the other treatments besides TPA that could be done?
Well, we can in some of the more specialized centers, there are doctors that can thread catheters up into the blood vessels inside of your head, much like a heart catheterization, and open up the blood vessels with TPA, but also using devices that can actually mechanically disrupt the blood clot in the blood vessel, almost like a Roto-Rooter kind of device or a drain cleaner. But those aren't available in every hospital in West Virginia, but there are facilities where we can do that. And sometimes patients are referred to us in Morgantown or other facilities in the hospital or in the state from smaller hospitals around the state to have those things done.
Just a reminder, our phones are down in Morgantown tonight, but you can email us at doc at wvupubcast.org. So, Lori, what is the difference between an ischemic and a hemorrhagic stroke?
The difference is in an ischemic stroke, there's something that's blocking the blood flow to the brain, so the brain gets starved from blood, and you get a part of the brain that is essentially dies, like a heart attack.
Right.
We commonly think of heart attacks where the blood vessel gets blocked. The same thing can happen in the brain. Another scenario would be that you get bleeding into the brain, either because of, most commonly because of high blood pressure, so too much pressure flow, a blood vessel ruptures, and you get blood in the brain. And they can look very much the same. Right. The important thing is recognizing one from the other, because obviously you don't want to give a clot buster to someone who's had bleeding in the brain.
Well, and we mentioned in the video that John was in the CT scan, the CAT scan, within 15 minutes of getting to the emergency room. So very quickly found out what was going on for him.
The important thing, so that's the whole thing about having a stroke team and a whole hospital focused on the treatment of a stroke patient, because what you want is, even before the patient hits the emergency room, if the EMS can call ahead of time. So the EMS is a very important partner to this whole team as
right.
well. So the pre-treatment, before the pre-emergency room treatment is very important. They many times the EMS recognizes this as a stroke. They call ahead. Then people are mobilized. So then you have the CAT scan is waiting for the patient, because that's the branching off point. Is there blood or isn't there
right.
blood?
Now, what do you do if it's a hemorrhagic stroke, if they're bleeding? Can you do surgery to stop it?
Sometimes surgery. We have to stabilize the patient, but they're not candidates for TPA.
Right.
But when a hemorrhagic stroke occurs, one of the most important things you have to do is figure out what caused the hemorrhage. Very often it's from hypertension, and they had bleeding from a ruptured blood vessel in the depth of the brain, but sometimes they have an aneurysm ruptures, which is a sort of a balloon on a blood vessel. Sometimes patients can have vascular malformations that they're born with, which are tangles of blood vessels in the brain. There's other inflammatory conditions that can cause bleeding in the brain. So for the hemorrhage patients, they need very careful, detailed evaluation to try to determine the cause of the hemorrhage, and then we can tailor the therapy based on that.
Now, does blood pressure have to be high for a really long time to have a stroke? Is it generally, or is it someone who knows they have high blood pressure, or is it kind of a combination?
Oftentimes, by the time the patient has a stroke, they may or may not have known that they had blood pressure. The thing about high blood pressure is that, it's silent. You don't know you have it. Sometimes people say, oh, I know my blood pressure was up because I had a headache, but many times there's no sign that your blood pressure's up until you have the stroke. And so that's a big problem. And many times patients will come in, they have this bleeding and they have the high blood pressure, and no one's recognized, but they usually have had it for a period of time.
So we have an email from Amy, and her question is ringing in the ears a sign of stroke?
Ringing in the ears is usually not a sign of stroke by itself. Usually you'll have other physical findings or other complaints on the part of the patient. Ringing in the ears is usually related to problems in the ear itself, but it should be evaluated.
And a little more information, if the man was 52 and had high blood pressure as well, could that make the ringing in the ears?
Might make it more of a problem, yes.
Okay. So it might be, the blood pressure is a good thing to get lowered and then get a full evaluation. And
that's correct.
And find out, what's going on there. So other things that are risk factors, if you have a family history,
Family history is, to a certain extent, a risk factor. Certainly, hypertension, diabetes, hyperlipidemia, those things tend to occur in families. But if you have a family history of subarachnoid hemorrhage from aneurysms, there's a slight increase in relatives, close relatives, for aneurysms there. And there are certain blood clotting disorders that can occur that they're congenital problems, but they may not become manifest until you're 20, 30, 40, 50 years old, and they can run in families too. So yes, family history is a risk factor, but it's usually related to other associated illnesses.
Right. So we have another email from Di, whose question is, he's having multiple TIAs over years with slurred speech and weakness. And does that put him at risk?
Yeah, certainly it does put him at risk. Anybody who has multiple TIAs is just as even a single TIA is a problem. If you have recurrent TIAs, that is just as much a risk. And the key thing about that is you need to be evaluated to see if there's something you can do to prevent it. Now, sometimes it's because there's a problem in a blood vessel. You may need to have a surgical procedure. It may be that you have to have something else done.
So I guess he has antiphospholipid syndrome, which is small vessel disease. So can something be done about that?
Well, that actually is one of the treatments for that is medication. So aspirin, sometimes with Plavix. There isn't a perfect treatment for it, but usually we just start with aspirin.
So as a blood thinner.
A blood thinner, something to, and aspirin is still the best first treatment for stroke, which is nice because it's not very expensive either, but it still is the best first treatment for stroke prevention.
And aspirin, I guess, is also recommended for heart disease as well. So you kind of get a double twofer there, and it's inexpensive. So if you have a family history and you don't smoke and you control your weight, and you get evaluated. Now, if you have a family history of having aneurysms, should you have a brain scan, or is that something to maybe be evaluated and talk with your physician about?
Probably talk to your physician about it. I think the risk if you have a mother or father, brother and sister that has an aneurysm, there is a risk of you having an aneurysm too, but it's not one-to-one. It's not one-to-one. And the testing that we do for that, there is a little bit of risk associated with the testing. The testing is not nearly as dangerous as it was when I was a medical student or a resident. The technology's improved, but there's a little bit of risk for it. So it's probably on a case-by-case basis, and you want to discuss it with your doctor about that.
Now, we talked about the symptoms. I still think that there are a lot of things that you could see with stroke, some very subtle things.
So sometimes people can just be dizzy, so they can have a spinning sensation, and that can be a sign of stroke as well. So the sudden onset of staggering and feeling like you can't keep your balance, that can be a sign of stroke as well.
Headache?
Headache, not as commonly a sign for stroke, but it can be, and especially if there's bleeding. If it's a hemorrhagic stroke, a bleeding stroke, headache is much more common.
And then sometimes people do get visual changes, or do they get floaters, or more lose vision in the eye?
They can lose vision in the eye. They can have double vision. So both of those are very important things. If you lose vision in one eye or the other, even if it's only a partial vision loss, it's really important to go to the emergency room. It may be something in the eye itself, but it could also be a sign of stroke. And double vision is another one that you need to be concerned about.
Right. And what are some new things on the horizon? Are there new things on the horizon for stroke?
Well, there are new therapies that are coming out. There's research going on now with new clot-busting drugs and new paradigms to try to make the decision more appropriately when we can give the clot-busting drugs and ways in which we can extend the window and still be successful and relatively safe.
Right.
So there's a lot of research going on about stroke right now.
Right. You mentioned the 3 hour. I keep hearing the 3, and then we've heard 4.5 hours, I guess, in the video. But really, you get in before that 3 hours if you need it. But say you went to bed and then you woke up with symptoms. I guess you don't know when they started.
You don't know when they started, and that's a big problem. And it is so common that the patients wake up and they're weak on one side or having difficulty talking, and then they bring them to the emergency department, and we don't know when the thing occurred. And then that really makes it difficult for us to make a decision about when we can give these clot-busting drugs and when we can't. So this research trying to extend the window out with new types of imaging devices to look and see how much salvageable brain is left may eventually be able to help us with that.
And so is the problem that the person could bleed in the brain or bleed somewhere else in the body? Is that the problem?
With the IV TPA, probably the risk of symptomatic hemorrhage is about 6 or 7%. So 6 or 7 patients out of 100 will have significant bleeding in their brain with this medication. Now, the data shows that even with that risk, if you give the medication to large populations of patients, they do better than if you don't give it to them.
Right.
But there is a risk of hemorrhage. And the problem, one of the issues is if you give the blood thinning medication out past that 3 hour window, then the risk of hemorrhage begins to increase. And you reach the point where it really doesn't help to submit the patient to that risk of the medication, because you might cause them to have bleeding inside their head.
Mm-hmm. And then you have a hemorrhagic stroke on top of that.
Right, that's correct.
Right. And so what are we doing post? You get to the emergency room, you get the appropriate diagnosis and then the treatment. Then what's ahead?
So the key things after the treatment is, one, to make sure you're safe. So you have to be closely monitored, and on top of that, it's really important to recognize things that may be silent problems. So many times people, after they have a stroke, have trouble swallowing, and that's not something that you recognize because it's not something that we even think about. We don't think about swallowing. We swallow all the time and we don't think about it. But after a stroke, sometimes when you swallow, things are going to go down the wrong tube, right? And they're going to go into your lungs and you're going to get pneumonia. And for many patients with stroke, that's what ends up causing their death, is that they aspirate and they get a pneumonia. So a lot of the things that, again, part of the whole stroke team approach is to make sure that the patient has a swallow evaluation before you start feeding them, before they start taking pills, aspirin by mouth, all the things that we want to do to try to prevent anything further bad from happening to them. And then maintaining their blood pressure at a safe level, and making sure that you have to watch patients after a stroke. Depending on the size of the stroke, swelling can be a problem, especially within the first 72 hours after stroke. So keeping people safe and keeping them monitored closely. Once you get past that point of, once people start to improve, then we start thinking about rehabilitation, and that's a really important part of what we do, and something that's really important for getting people back into their activities of daily living.
So we just have a short time. We have one more email from Nancy. She's having migraines and hypertension and a cholesterol over 300. Wondering, is that a precursor? Are the migraines a warning that she could have a stroke?
As Lori said, headaches by themselves, headaches are very, very common. And so they're generally not recognized as being a strong warning sign for stroke. Now, there's certain kinds of headaches that are really indicative of a problem with stroke, but generally not.
But it's her hypertension, her blood pressure, and her cholesterol.
And the cholesterol. And if you have migraine headaches, your risk of stroke probably goes up just a wee little bit, but not very much. But the big issue is the blood pressure and the cholesterol.
So she needs to get that under control.
That's right.
Right.
Add one other thing to what Lori said. When the patients come to the hospital, another thing we do is we try to figure out why they had the stroke, so we can modify their risk factors and reduce their risk of having another stroke in the future. So if they had hypertension, we treat that. We check their lipids and make sure if they got high cholesterol, they go home on cholesterol pills.
Right.
And if there's a problem with their heart or whatever, And that's part of the evaluation you get in the acute care hospital before you leave the hospital for the rehabilitation center.
So it's the key is time is of the essence. Call 911, get to the emergency department, and then get evaluated for why you had a stroke before you go home, so we can prevent any further problems and damage. Right. So we've been talking about stroke with Dr. John Brick and Dr. Lori Gutman. Thank you both for being with us. If you'd like more information, talk to your family doctor or visit our website at wvuhealthcare.com. For Doctors on Call, I'm Dr. Kathy Moffat. Good night and good health.
Doctors on Call will be back live on Thursday, April 21st. Join us then. Major funding for Doctors on Call is provided by a grant from the Milan Charitable Foundation. Other funding is provided by the Health Plan, a health maintenance organization serving West Virginia and Ohio since 1979. By the Center for Organ Recovery and Education, supporting Volunteers for Life through organ, tissue, and corneal donation. By Health South Rehabilitation Hospital, serving your rehabilitation needs in Morgantown and Fairmont. And by the faculty and staff of the Robert C. Byrd Health Sciences Center of West Virginia University.
This has been a production of West Virginia Public Broadcasting.